first panel to come up on board so we can begin the day. We're going to be talking about coming out of the pandemic. So I'd invite John Leisman and Phil Berry, David Hines, Kim Hutton, Catherine Quadrazzi Flores, and Adam Johnson to come up. What we want to do in this first panel is to have you hear from leaders in the industry, people who have vast experience in on-site, near-site, mobile, and virtual care, to hear what they think the future holds for us and what some of the key questions. So just pick any spot here, be fine. And then again, during this time, if you have questions from what they're saying or anything about the conversation, please feel free to text me. So let's just start out with some introductions. So again, David, a quick introduction, and we'll go to your left.
David Hines, I head up the benefits at Metro Nashville Public Schools.
Should be on, John.
Hello, I'm John Leisman, Chief Medical Officer of Premise Health.
Hi, I'm Kim Hutton. I'm Chief Medical Officer of Evernorth Direct Health.
Dr. Catherine Quadrazzi Flores, president of Quad Med. My father started the business 31 years ago when I was heading off to med school.
Adam Johnson, Chief Strategy Officer of Worksite Health.
Phil Berry, founder and CEO of Northwind Pharmaceuticals.
Great, thank you all. All right, let's just start out. So John, let me start out with you. How have health centers evolved in the last 2 years, and what lies beyond the pandemic?
Well, I think ultimately the answer to that has its roots in lessons learned during the pandemic. And that's probably worthy of a dissertation in and of itself. There are a couple of things that stand out to me. The first of which is primary care is really important. The second is that medicine is ultimately at least as much an art as it is a science. So let's take the first one. Primary care is really important. We know that individuals who had established primary care and healthy primary care relationships before the pandemic fared better. They were more likely to get vaccinated. If they did become ill, they were more likely to get good treatment. And if they needed to access the system for whatever reason, they already had a gateway to do so. Going forward, the challenge is going to be to drive individuals into primary care relationships. It's going to be driving people to get immunizations, to get up to date with their preventive screenings, for condition management programs, and to establish overall relationships with primary care providers. This also is tightly intertwined with establishing trust, reestablishing trust in our health systems. We know that throughout the past few years, there are many people who express skepticism, and we need to have people engage meaningfully with their doctors and with primary care in general. The last element I would say is helping to build primary care infrastructure. It's not just the primary care that we're familiar with from days past, but it's having truly integrated platforms where there's behavioral health, there's condition management, there's tight coordination of data-driven referral networks. We also know that pharmacy services are important, and that's a key element of that greater primary care landscape. When we think about that other piece about medicine being as much of an art as it isn't a science, we need to connect with people. And I'm very particular in my words here. We need to connect with people, not with patients. And there's a difference. Patients are already established. There are a lot of people out there who are not established. And this means we have to pay particular attention to whole person care. So things like delivering culturally competent care, paying attention to social determinants of health, being aware of implicit bias that might exist in the system, and having cultural humility. The successful on-site clinics of the future will be able to fully integrate platforms that include the wide expanse of primary care and to engage and connect with all individuals.
Thank you, John. Kimberly, your thoughts?
That was perfect. And I would agree with all of that. I think you covered just about everything. I think the thing I would add is there's a difference with employers now. We were talking, a few of us were talking a little bit about this beforehand. And, 15, 20 years ago, this business, it was a Wild West, and employers would come to us and and they'd say, well, what do you have to offer? And we would say, this is what we do. And it has really changed nowadays that employers have become sophisticated. And I think that the pandemic really emphasized the need for them to ensure that they're taking the best care of their people as they can. And so they know what is going on in their population. We have, we've talked about data-driven analytics and the care that comes out of that. That is more important than anything right now. And employers are focused on that. And now they come to us and say, here's the problem. How are you going to help us fix it? And so I definitely think that the relationship the employers have with their own people has further strengthened, and it's really shined a light on the needs that they have to ensure that they've got a healthy population.
Sarah, Catherine,
Same question.
same question.
I mean, it's all of the above of everything you're talking about. It's being solution driven because each population of each employer is different, even within. So we're owned by our mothership Quad, which is a very large printing company that has a national footprint and actually an international footprint. And so solving their problems is different if I'm in Lamira, Wisconsin, than I'm in California. The demographics are different. The patients are different. How the patients want to connect with us is different. And so getting that customized version of really listening to where the people are at, not just the patients.
Adam?
Yeah, maybe just two quick things to add. I think number one is clearly when you send 300 million people home and have them stay there for varying lengths of time. I live in Texas, so it was about like 5 minutes. People were at home in Texas, but in other places, perhaps longer. That fundamentally changes an employer's relationship with their employees. And I think that dynamic has caused different engagement strategies to be relevant. It's caused a different set of disease states to be relevant. It's certainly caused a tremendous focus on mental health, which I think is interesting because it's not like there weren't mental health challenges 3 years ago. It's just that when people have to go and spend a lot of time by themselves, that becomes more clear and more tangible that it's an issue. The second thing I'd say is perhaps a little bit different take on what you're asking, Larry, which is in a lot of ways, I actually think nothing changed. Right? We still have people that are diabetic, and we still have people that need cancer screenings, and we still have people that fundamentally need to get access to care. The pandemic changed nothing about any of that, but hopefully it did focus our attention on actually impacting those populations and trying to help people live healthier, happier lives along the links that their careers allow us to touch them.
Thank you, Phil.
Wow, how about that? All great answers. I think the only thing I can really add to this, employers have invested in on-sites, near sites because they want influence, because they're trying to become closer to the outcomes, the costs of their employees. They're trying to help them thrive. So I think the pandemic, one, revealed some places where we need extra help, but it also highlighted the importance of these investments and these resources, because to Adam's point, people weren't able to get access to care. Our health systems were overflowing. So we had really an opportunity to show up for our employees and for our employers. Employers are expecting us as partners in this process, as clinic managers, as pharmacy partners, as consultants, to come up with ideas to help them solve these problems. And so the opportunity to influence the health and well-being of their patients, of their employees, that's why they invested in it to start with. And we learned that the experience of our health system is a problem with it, not just in access, but actually in how it's being used and what we need to do to influence it. So I think that all great answers. I was particularly happy to hear one about pharmacy services. Thank you, John, for that one. It's good plug on that one. But we learned a lot in it because they're now expecting us to show up in a way and be strategic when they're facing major problems. And that means, how do we stay open? How do we bring virtual care? How do we access people where they are? How do we get people where they need to be? And also, what should our policies be? And these are all great opportunities for us. And I think just a great set of answers for that question.
Thank you. So David, from employer perspective?
The pandemic forced so many changes on us. I mean, we all of a sudden, everybody had to pivot and go into this virtual world. And now, are we still holding on to that virtual world coming out of the pandemic? Mental health became such a focus on things, and we opened up doors to make sure there weren't barriers to care, and we kept on looking upstream to see what's going on and see what's going on. We paid attention to why people took vaccinations or didn't take vaccinations, and what were some of the demographics and the shifts in the population. that's going on. We took a look at different parts of our population that were being impacted more readily or greatly by the pandemic and tried to start thinking about what we can do to do that. These are all lessons we learned in the pandemic, and we have to hold on to them as we come out. And at the same time, what I'm seeing from my perspective is all of a sudden the venture capital market really realized that there's a lot of movement, a lot of activity should be going on within our market as we can work together to make care more readily available, whether it's walk in the door or whether it's a telephone or a video conference or whatever the aspects could be shipping the providers directly to you. And all of that's changing our marketplace. And we have to figure out how we're going to integrate and do that, because they're great tools, but we have to figure out how we're going to sort through them and apply the right ones and use that to expand our reach. I believe that we can take our hubs, our on-site medical centers, and we can use them as that hub, and then we continue to work upstream with specialty in different areas, and we need to access all the levers we can, because we started with primary care. The future is having this whole health model that's out there, and we have to figure out how to get to there from where we are today and how to build those partnerships and continue to move ahead.
Thank you. Catherine, let me ask you, what changes or services are employers looking for nowadays?
I think everyone in this room is working together to furiously pedal forward to frictionless, coordinated, data-driven. That's the holy grail, that, you know, what we do matters if we can get to that. And we have to meet patients or people wherever they are, whether it's at home, whether they're at work, whether it's a concentrated population or distributed population. And some of the just anecdotal, you know, things people are asking for. Number one, behavioral health. That's huge. We know that. At our mothership quad, employees were having a hard time knowing who to go to. Do I go to the EAP? Do I go to Quad Med? Do I go to into the community to get behavioral health? Where, by the way, it was a month to get an appointment, 2 months in some areas. So we put together a 1-800 mental health hotline for the employees. And then we help them navigate to whatever it is where they need to go, whether you're in person at a clinic or in the distributed population that doesn't have access to a clinic. Number two, virtual primary care. Now, we all pivoted in some way or another to virtual primary care during the pandemic. We had to. And boy, were we lucky that Zoom was available and all those things were we had those tools in our belt. But now people are asking for virtual only primary care, where you will never see the physician or provider in person. I was a little skeptical of that, but then you realize how many people don't get access to care. They never have an on-ramp on. So that is, and in some ways it's better because it's instant access. I don't have to get a babysitter. I don't have to find time out of my day. I can just beam in. And so the virtual primary care only is something that we're building. And at the same time, all these other virtual things, virtual PT, hey, can you do virtual OcMed for us? So it's a multi-channel world, and we have to, our people are used to in the regular world as consumers having many different ways to access us. So some people, some populations like to call us, some like to Zoom us, some like to email us, some like to text us. We have to find that way to meet the needs of that population. And then number three, social determinants of health is a big one. I was just at the EPIC CEO Council, and there was a pediatrician who's a really good pediatrician who said, I thought I knew my patients until I started asking them the questions about social determinants of health. And she was shocked to find many of her patients were food insecure, patients that she had known for years. So getting to that frictionless, coordinated care with the primary provider who can be that central brain to bring it all together, that's the holy grail. And I really think we're getting close.
Adam, what do you think employers are asking?
So couple points. So I'd say the first is, I would think about the sheer amount of investment that has gone into the digital health space in the last 10 years or so. Something like $85 billion has been invested in digital health companies in the last decade. There is a solution that fits every need that could possibly exist. For those of you who are plan sponsors, I'm sure you are absolutely sick of hearing from people every single day. You're sick of my salespeople. You're sick of other salespeople. You've heard from everybody. And it's probably for solutions so niche, you can't even believe that there's someone who came up with a company to do this. So I actually think, Catherine, to your point, I think it's the coordinated piece. I think that's more important than anything else. I actually really don't believe that an entirely new solution is going to pop into existence in the next few years that someone hadn't already thought of. I think the game at this point is, how do you actually take all of those things and start to put them down a path where patients understand what they actually are? I remember a handful of years ago, I was the president of a health navigation firm, and we sat down and did a bunch of focus groups with individual employees. And this is for a big company in Texas. And we started asking people, what's your favorite benefit that your employer offers? And people really couldn't answer the question. So we kind of started doing true false. It was like, well, here's a benefit that your employer offers. What do you think about this one? I've never heard of that. What about this one? I've never heard of that. How about this one? I've never heard of that one either. And that particular organization was probably spending $30 or $40 million a year on a set of benefits that not a single person could name. If I were an employer, I would focus on that more than anything else. And I actually think that on-site, near-site, primary care, the infrastructure that we're talking about here has an ability to really guide that. And the pivot I would suggest that we have to make is, we have to stop thinking about that myriad of point solutions as being things that we offer people. And we have to start thinking about them as being components of the treatment plan that is actually delivered to a patient or delivered to a person, depending upon the orientation of how you think about it. Once that shift happens and you start thinking about primary care as simply being a vehicle to connect each of those individual tools, I think that's the thing that really fundamentally changes the market and ultimately delivers those of you who are plan sponsors the thing that you actually need to have and what your patients ultimately need to have.
Thank you. Bill, what are employers asking you in the pharmaceutical area?
I'm going to take just a step back from that a little bit. I think one of the things that we're seeing market-wise, there's a lot of noise right now about cost, right? Everybody wants better costs. Mark Cuban Cost Plus, we hear about all the different cost things. And so often what happens in that is we get so obsessed with cost, we get into a spiral. It's a race to the bottom. And what I mean by that is we miss the opportunities for value because we're so centered on cost. We're so centered on how we evaluate options. We're so centered around what the structures are for it. And employers they're tired of that actually. And I know that because they all want the best price. We get that. We all want the best price. And when we went out to market and we started saying, okay, well, what's the right cost? What do you want? Well, we could go out and offer 15, 20, 25% savings, and you'd still have people, organizations that wouldn't change. And you start thinking, okay, all right, so what is it? And what you find is it's something what we call stewardship. They want to be good stewards of their resources. And so a lot of what we're doing today, the whole reason these health centers came into existence is because you had employers who said, I want to get the most for what I'm investing. I'm investing X dollars a year and I want to get the most for it. I want people to be healthier. I want people to live better lives. I want them to be more productive. I want them to feel good and know what their benefits are. I don't have to sell them on my 35 shiny objects. I want them to buy into it. You want it to work. So stewardship really from an employer perspective is making it work. So then what do you do with that? Well, this notion of this center of influence. So for us, we call it, it's a nexus of care. So employers are looking for a point where they can actually quarterback everything that's going on with it. I'm investing millions of dollars in a health center, in a plan, and whatever. And they're all in these silos, all not integrated, all often not talking to each other. I was at a recent vendor summit where there was a conversation about mental health. We have an EAP over here, we have a clinic, we have this. The clinic says, I'm going to refer this patient, these employees into your EAP. Oh, great. That's a great idea. We love that. We'd like some feedback so we can kind of coordinate care. Well, will they go to legal? Because there's a certain set of agreements. And I don't think we can share that information with you. And immediately you see everybody start rounding out like, oh, this is my turf. And that's what happens. And that's what employers are sick of. They're sick of all the silos. They want the ability to influence. And so for us, it's really about reimagining the experience. The experience of the employee, the patient, in terms of how they access, and frictionless is it's a great way to characterize that. How is it easy to do this? How do I understand it? But it's all the stakeholders. It's the employer. It's the providers. We all want a better experience. We want to know what the plan is, what the benefit is, what's the best point of access, what works, what doesn't, what do I have to pay for, what's it going to cost? Who's heard transparency? Yes, quite the constant word right now. It means a lot of different things, but that's a desire to want to understand. And so what we're hearing is we want new ideas. We want a better way to do this. We want to look at old models and not just be given red or blue. We want to know that there's different ways to do it. And when we invest millions of dollars, we want ROI, but what we really want to know is we got the most for our money, that it's actually working and people are being healthier and my costs are going down and I can predict it over some period of time. Because at the end of the day, we're really talking about managing risk. Risk and a big self-funded plan it's a big deal. So how do I best manage that one? And you've got smart employers who are finding ways to do that. And they're calling on us to come to the table with new ways to coordinate it and to reimagine it, both payment-wise and also how it's engaged. So I know it's a mouthful for just what do you think employers want? But the reality of it is until we start thinking about reimagining the entire experience on through the clinic, on into surgery or wherever I need to go, we're going to continue to thrash in this same spin cycle of this or that, or race to the bottom, or this is how we evaluate it, or this is what the plan says, deductibles, copays, all that stuff. It all needs to be looked at. The great opportunity for us in this room and why this organization I think is so valuable is that we have a chance to be on the front side of that conversation in a meaningful way and say, here's a point of influence. We call it primary care, but it's your nexus. And it's a way to help reimagine all these things out there. And so I think it's very exciting. And I think employees are asking for it. It's coming in many different forms, but we're all being asked for the same thing. And we're all kind of fighting for the same thing. It's just usually we're fighting against each other as much as we're fighting against the problems that we've got with it. So my 2 cents.
Thank you, Phil. David, what are your expectations now of your vendor partners and what are you asking for in the future?
You know, innovation is a big part of what we're doing. Like I said, I'm trying to figure out how we best work upstream, how we take some of the gains that we made in the telehealth world and better integrate it into our thing. I'm sitting here at a point where I've got 51% of my employees touch my clinics in a year. 46% of them use us as their medical home, and about 37% still attached to primary care in the community. What Phil was touching about, when it comes into this whole issue of integrating and leveraging our clinics as a nexus of care, we really try to do that. When we bring in new programs, new benefits, we take time to educate our providers and make them as part of the whole thing, because you know what? They're the ones that will direct care, and where somebody might not listen to me when I try to tell them this is something that can help you, they will listen to their medical provider, and they're more likely to use it and be engaged. And if I had an EAP that said they're not going to work with my providers and share information, I'd fire them. But and I think that's the approach we have to do. We have to demand responsiveness. We have to demand integration. We have to demand people to work together. And I had an old boss, he was an old military Army colonel. He said cooperation was a condition of employment. And I think we have to hold that aspect and that dream out there for their folks, because they have to work together. If we're going to improve, we have to work together. And so whether it's dealing with the hospital systems, and we have great hospital systems in Nashville, I'm proud that I got my folks from Vanderbilt, but I also have Ascension St. Thomas in the room as well. The provider community is ready to work with us and to help us go upstream. And people in my place need to be aware of that and be ready to have those dialogues and step outside the norms. And I'm sorry, Evernorth or Cigna or Blue Cross, sometimes we have to step out on our own to get things going, because we can actually move things a little bit faster than the TPAs.
Thank you. Don, what are employers asking for?
I think more than anything else, right now, employers want help. And if you think about it, unemployment, something like 3.7%. Employers can't find workers. They certainly can't find trained workers. Inflation is creating wage pressure. Interest rates are up. There's supply chain disruption, and healthcare trend lines are going up. CEOs yelling and pounding on the desk. David, you mentioned working together, and I think that's what it's all about. And ultimately, I see us in kind of a transformational period where the on-site clinic industry is moving from kind of a vendor model to more of a partner model. You think about complex legal advice, complex accounting advice, consulting. If there's a challenge, Fortune 1000 company, they call up McKinsey, they call up Bain. They go to the biggest legal department or law firm in town. They call up KPMG or Ernst & Young. We're at a transitional point where there is so much complexity and detail and need for integration across fragmented point solutions that employers really do need expert help. And I think more than ever before, that's what they're looking for.
Kim?
Wow, there's not a lot to add. I think everything that's been mentioned, what I would put a little finer point on is, I think David's absolutely right. We need to be innovators. Phil said, we're on the front edge. Most of us, if probably not everyone, has experienced healthcare on the other side, and they're still reactionary. They're not being proactive. And we have the ability to be innovative and to find new solutions. And I think that's certainly come out of the pandemic. Like we mentioned, there are a lot of digital solutions out there. There's some amazing things happening in genomics and chronic disease management and care coordination and navigation. And we should be the leaders in that space and really pushing for that innovation. I also just want to reiterate the fact that true integration is necessary. We cannot be fragmented. We can't offer one solution and then you have 10 other vendors who are offering other solutions. You need to be not just coordinated, but I would say integrated, and being able to understand the health plan and what the health plan offers, what each of your vendor partners offers, and truly integrating, have that data flow seamlessly and frictionless. I love those words. And so again, I would just say innovative and integrated. It's really the key to the game right now.
Thank you. Adam, let me ask you, how has the provider vendor role changed to be more advisory for employers than just a typical vendor?
Yeah, I mean, this sort of goes back a little bit to what I was talking about a few minutes ago. We certainly at Everside have a tremendous number of clients coming to us and saying, we've hired you. You're the very most visible thing inside of our health plan. We've carved primary care out. We've carved mental health out. You are now in charge. Go run the show. And, suffice it to say, I mean, I think when you're delivering primary care, you're not going to be the cheapest solution that the employer is buying. And I think in part, when you are a relatively expensive option, you are ultimately going to have relatively significant responsibility. And I think that's okay. And I think that's the way it fundamentally should be. And so I think a lot of what we have seen is organizations coming to us and saying, well, what do you recommend in terms of change? And one of the more interesting sets of conversations we got to have just a handful of months ago was we actually sat down with some plan members and got an opportunity to talk to them and one of our larger clients. And when we did that, we started asking them some pretty basic questions. We said, well, why are you not getting preventive care today, for example? And I think what the expectation was of the plan sponsor, and to some extent, probably what our expectation was it was going to be health literacy issues. It was going to be access issues. It was going to be things like that. But in fact, what this group of people, and it's a very classic blue collar employer, came back and said was every single one of the people said, look, I actually know I need to get this care. This is really, really important thing for me to do. I know where I need to go. I just can't afford the diagnosis that I might get if I get it. It's a pretty stark reality to have a group of people sitting there looking at you and saying, I know I'm diabetic, but I don't want to have somebody tell me I'm diabetic, because if I find out I'm diabetic, there's a set of medications I have to take, and there's a set of visits I have to take. And there's a 0% chance that I can afford any of that. And to have had the opportunity to have opened that dialogue with that plan sponsor really gave us the ability to start talking about, well, what are the fundamental shifts you probably need to make and what your plan design looks like to be able to do that? What is the intersection with how you think about your pharmacy plan? What is the intersection of how you think about working with your carrier that you have? And, probably 10 years ago, I don't know that someone would have had that conversation with somebody that was running their on-site or near site. But I think as we offer a broader set of services, as we engage relatively more people, as we show a demonstrated ROI as part of the package, we ultimately get the opportunity to guide some of that conversation. And ultimately, I think that is where a lot of the impact happens. And that's where the change can happen that really impacts those individual patients.
Bill, your perspective on being an advisor to your employers?
I think Adam's response is really good. And I definitely think that's part of what they're asking. I think what I'm going to focus on is something a little different in the front side of it. So we see one of the things we do frequently is we do a lot of analytics. We do a lot of reviews of data. And what happens out there is there's a lot of data. There's big data, there's little data, there's a lot of data. But there's a lot of data vomit, right? So there's all this data and we just dump it on our employers and say, there you go. Look how bad you are. Look how bad your people are. Please insert 15% more this year. And that's something nobody likes. And so what we figured out was, all right, so how do you sort through all the noise of that? And what we found was there's this request around, everybody wants visibility. What am I spending? What does it mean? Where are my problem areas? But they also want understanding. And there's a lot of advising around that. You know, in the PBM world, they reprice, which is the shell game, right? All right, so I can do better here. I'll save you money there. I'm just gonna, whoop, and we'll just take this off. Ingredient costs, whatever it may be, you see it. And so what employers want is, okay, when I'm looking at this information from a health center or from a cancer center or from anything, what does it mean? Okay, so they want us to tell them, help them understand, what does it mean? Now, what do I do about it? What are the actionable insights within all this noise? And the easy thing is to say, gosh, I actually, this is a true story, if you don't mind me telling you, I was actually at a review over some period of time ago with some unnamed organization, and they were talking about what they did the year before and what the results were as employer and a health group and so forth. And when they asked, okay, what do we do? And the person who was a physician provider said, we need your employees to eat more fruits and vegetables. And I was like, okay. So on the scale of what employers want, not helpful to give me something useful. So what we always do in that case is when you're sorting through the noise, break it down into something they can do something about, usually 1 or 2 or 3 points to start with. And where do we start? So when I get visibility, I want understanding, then I want some direction on it. And so for us in the space who are acting in that advisory role, yeah, there's broker relationships and there's consultant relationships and all that's out there, but we represent healthcare. We represent the medical or the pharmaceutical or the side that's actually interfacing with a patient, a person whose life is being put in their hands, who's counting on them for help. It's a trusted responsibility. It's a trusted relationship until it's not. And it needs to be trusted. And so when you have that, your obligation is to help them sort through it and then find places to start, knowing organizationally there's going to be barriers and resistance and other incentives and hidden incentives and misaligned incentives and all this stuff. So we have to find ways to really advise that and help them navigate it. So I would just layer on data vomit, sort through it. Let's find some place to start and help them understand it.
Thank you. David, are you seeking more advice from your vendor partners?
I always look for good things to come from them, and I hope that I will find good things. There's a couple things that, I like for them to come to me with good answers or good solutions, but also because I'm always stirring something up to keep me from doing something stupid. So be honest back with me and be my check on the reality of things, because they have I see something shiny and I like it and I think that's neat. They need to tell me what's on the other side of the coin to make sure I don't jump after something that I shouldn't. So an open, honest dialogue that goes both ways is a great thing, and good insights and moving ahead.
John, you finding your clients coming to you for advice?
Absolutely. More and more, I think, as time goes by, and often it is just understanding or learning what questions to ask. We're in a system now that's so complex, it's evolving so fast. There's so many individual solutions out there, as was referenced before. It's hard to make sense of them. You know, I'm very fortunate in my role. I have a team of about 85 clinically trained professionals who can evaluate a new product, technology, service, or vendor. If you work in a human resources department and you don't have a clinical background, or if you're in the C-suite, you're on the finance team, that can be very foreign to you. And being able just to offer a little bit of guidance and to put some clarity on that is an increasing demand.
Sure. And I think I'll take just a little different approach. A lot of times, you know, we throw out these buzz terms, being consultative and in an advisory role and, you know, those types of things. But I would say that the employers are coming to us now. There's been so much thrown at you all from the digital perspective to new services that oftentimes you're coming to us. We want to help lead you, but you're coming to us. We're working with the David Hines of the world who have these really amazing ideas. You also understand your population. And so what we're being asked, like John was saying, that you know, let's take a look at this and let's vet it completely and let's make sure that this is the right solution for you. But the employers are really they're approaching it as a partnership. And so that's what I love about this business is that the employers that you really understand your people, and especially coming out of the pandemic, you're trying to do the right thing.
Kim, let's stay with you. How do we recapture the utilization that we lost during COVID and people not coming to center?
Yeah, absolutely. I think we've already said a lot of the solutions. First and foremost, I think you need to meet the patient where they are. We recognize that a lot of the population is not going back into the office. And so we are at a pivotal moment in just the employer space, but also in healthcare. I think as a physician, and probably anybody else here who's a physician, we fought virtual care for a very long time. You couldn't do it and it wasn't effective. And oh, by God, I got to lay my hands on the patient. And what we realized was, wow, it's a really great solution for a lot of people. So whether that is at home, at the workplace, digitally, telephonic, video, whatever the case may be, we've got to meet the patient where they're at. And I think that is one way to recapture. And I think we've all said, you know, we're trying, we're working on solutions that will enable us to get into the home, into the workplace easier and meet that patient where they are. The other thing, and I think it's also been said too, is more and more people suffer from chronic disease nowadays. We are catching cancer diagnoses later stage. And, you know, we know that. And so recognizing that we need to place efforts on prevention and really getting those folks who have chronic conditions, who need to be managed better, touching them, whether it be through outreach proactively or reactively, whatever the case may be, we've got to address the health needs of the population because for 2 years we haven't been getting health care. And we need to, whatever we can do, whether that's through virtual services, outreach services, getting creative with how we treat chronic conditions, we've got to reach them and we've got to get them taken care of.
Catherine, how's Quad Med addressing the utilization challenge?
Well, in most of our clinics now, we're really back to where we were, and that's because our team, as soon as we went virtual, it didn't stop working, and our employers didn't stop working. I'm looking at my head of communications right now, taking my picture. We advertised, we tried different things. As my father used to say, we threw spaghetti at the wall and saw what's stuck. And for instance, I think it's important to talk about the partnership with the employer, because it's so critical. So to your point of the diabetic who is not going to go in because they can't afford the medicine, we have one employer who's like, okay, let's take away copays. Let's take away cost of medication for people with chronic disease. Let's give them that carrot to come in. So that's just one small, right? You fight for every single yard. And if you can fight together and then have your marketing team try this, try that. The revolution is always starting the clinic. But then there's got to be the evolution, 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 tweak, 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 because every day, particularly during the pandemic, wow, the needs changed instantly. And my husband's a thoracic surgeon. I don't see him much because of the backlog right now. He's operating all the time, but he just published a paper where they look at their average patient and now they're coming later. They're later stage. And he can see it already in the numbers. And so what we do matters. The screening that we do actually matters. And so we've got to work together with all of the different things to keep listening and then change what you're doing to move the needle.
Okay. John, what's Premise doing?
Well, there are a couple of things, and going back to the employer perspective on this and perhaps tying a couple of things together, one of the key elements is benefit design. And that's where advisory services can really come and play a role. But the reality is, if benefits help to drive primary care relationships, if they help to drive utilization of the health centers, you're far down the road of having utilization. In addition to that, we have a very active member engagement program. This also is where partnership, rather than just the traditional vendor relationship, comes into play with an employer. And there are a number of ways to achieve this. It all starts with the doctor or the nurse practitioner or the physician assistant who's in there. There is still sanctity and value in that trusted relationship. And word of mouth helps to build a practice like nothing else. I receive this question quite a bit, and I always take a step back and I wonder, in years past, when the general practitioner finished up with medical school or residency training, they went and they put a shingle up outside their door. Over a year or a couple of year period of time, they had to build up a practice, and they were able to do so. So why are things different now? They aren't. There's technology that can help us, but it really starts with that relationship. It starts with attending to whole person care, to meeting people where they are and to engaging with them, assessing what they view their healthcare needs as, and helping to deliver on that.
Thank you. Adam, what's Everside doing for utilization?
Yeah, so I would say there's a structural element and then there's a strategic element. So I think on the structural side, I think you have to think about the way that you're delivering care. You know, tremendous number of employers now have folks that literally will never set foot in their office ever again. If an on-site strategy was what you had relied on, that's probably not going to work very well, right? So I think it is increasingly a combination of it's on-sites, it's near sites, it's virtual, thinking about those, thinking about how you engage with folks that can give you the right network that allows you to access the right type of excellent care. I think that's so important. If you're relying on what I would say is a relatively older strategy, you're probably going to struggle. So that's the structural side. I think on the strategic side, a little bit related to what John was saying, you know, so much of the way that we try to engage people with respect to benefits strategy is, well, let's try to put that on page 1 or page 2 of the benefits guide, and then let's send out a small army of emails to the folks, and that's absolutely how we're going to reach them. That has reached no one ever. Right? And it's not going to. And particularly in a world where people get thousands upon thousands of emails every single week, and they're constantly getting outreach from all sorts of things, particularly if you've built that cloud of benefit I was referring to earlier, you're going to have people sending them emails from companies they've never even heard of. To some extent, I actually think that decreases your engagement. It doesn't increase your engagement. And so to the point around plan design, to the point around how do you send a message to your employees, to the plan members that you have, I think it's plan design. I think it is also, as you meet with them, as you talk about benefits, sending very clear signals. Your healthcare starts in one of these 2 places at most. You start telling them, hey, I want to introduce you to 37 different programs, you're screwed. There's no hope to be successful there. I think you have to be clear. I think you have to be specific. And I think you have to create strategic elements in your benefit design that make sure that this really is their first stop. And primary care really is the epicenter of all care. So it is the place you should want them to have as their first stop. You just have to be very deliberate about making sure that occurs.
Thank you. David, how did utilization get impacted, and what are you doing to get it back or to where it was or increase it?
Sure. I mean, when the pandemic, we saw probably about a 25% reduction in overall primary care during that period, even though we pivoted over into virtual care. But we always also had this thing about sick visits and well visits and having to separate and keep people things. We run 5 different clinics, but 4 of them are in remodeled classroom portables. And so there was a limitation of space. So you didn't want to run a bunch of sick people in together at that. But we have one nice 26,000 square foot facility that houses our wellness center that we took care of things there. What we saw during that time, we were able to see a nice uptick in the primary care virtual visits. We also saw we have psychiatric nurse practitioners. We also have health coaching and physical therapy. PT picked up and actually did better in the virtual world than I ever thought they would, in that situation. The psych NPs, just bless their heart. I mean, they were just being blown out of the water, and they're virtual then, and they're still virtual now. And what we've learned is there are some areas that work great virtually that probably will never come back to a real face-to-face except for occasional visits and check-ins. Mental health is one of them. The other one is health coaching. Works great in that whole world type situation. So getting back, what we saw is as we came out of COVID, and especially as we stopped the segregation between sick and well, our volume came back up on our primary care clinics. So it's there, but what we're having to figure out is how do we keep a hold on to that telehealth visit when it comes to the primary care model, and not trying to default out to a service like a MD Live, which is a great service and all, but I need something that integrates back with my clinics, because now my clinicians are busy again, face to face. But how do we adjunct what they are doing with other things, whether it's telehealth, whether it's home visits and beyond, to keep on working on this model and not just come back to where we were, but let's push ahead.
Bill, let me ask you, how does the need for offering services to now a hybrid, in some cases totally remote population, change the business model?
I think it goes back to the whole experience thing. So couple thoughts on that. So first of all, back to the data side, one of the big challenges of understanding is knowing where your problem areas are, what the priorities are. And then it's like anything else is who's part of those groups. And so one of the things that we've seen as we've come out of COVID and the shift back to hybrid, although I agree with Catherine, I think the utilization, we've seen people that are coming in, visits are kind of where they were. The bigger engagement issue is, are we getting the right people at the right time? And a couple of different ways to it. But for us, one of the ways we showed up and saw as an opportunity for it was to integrate things that can be done remotely. So we've got the telehealth options. One of the things we saw right at the beginning of COVID was we shifted our supply chain to our clinic partners almost overnight to where half the medication volume was actually going to patients' homes. And so there's some tactical things you can do to actually enable it, to Kim's point, kind of meet them where they are with what they need there. But I think the bigger question is how do we get the right people at the right time? And so one of the things that we've seen and are actually executing on is ways to engage, first of all, starting with the most expensive end of your spectrum, diabetes or whatever it may be, and finding specific programs that engage those populations. And I think Catherine touched on as well with regard to copays, deductibles. Why do we put these barriers in place when we know that downstream this person's going to cost us 5 or 10 times more with an episodic event? So that hasn't changed with hybrid. Hybrid work at home, hybrid coming to the office, people are still needing those things. So for us, the trick is how do we get the right people in and then and engage them in a way that they keep coming back. And then for those that are the screening related sites, how do we bring them in so we can actually catch things so they don't get into the wrong bucket. And that's what the actual insights kind of model is. It's saying here's our problem areas and here's how we engage them. And for us, we're not seeing dramatic differences from a hybrid side because I think a lot of both from a clinic manager perspective as well as how employers are engaging, we're seeing a lot more near site activity. So part of that meeting patients, employees where they are is also being closer to them in a physical, geographical way. So now the barriers to that, the access point has really been solved in many ways. The big question is how do we take it beyond straight utilization and true engagement to where we're seeing it move the dials on health outcomes and the high cost areas. So that's kind of how I'd address the hybrid question.
David, how have you addressed your remote and hybrid population? What challenges have you found?
Well, I work for a school system all in Nashville, Tennessee. So And they even made me come back to work this week. So I'm sorry. You know, as I mentioned, we did a lot of telehealth type thing, but I am a unique player in this thing because I take care of people in Nashville. And so if they work in Nashville and their teachers are back in the classroom, but also they live here in Nashville. So fortunately for me, I didn't have much of an issue. For those that do, bless y'all's heart. Okay.
Tanya, how are you helping the populations that are hybrid and remote?
You know, if you say something once, maybe people hear it. If you say it twice, it's a theme. If you say it more than twice, it becomes a paradigm. So I feel like we're starting to repeat things. But, you know, clearly benefit design, clearly access. And for us, that means 24/7 capability, whether it's at a physical site, on campus, if it's at a near site, or if it's by some sort of a virtual mean, member engagement platforms. But I'd also add, going back to this concept of meeting individuals where they are, that employees oftentimes will have an entry point with one of a constellation of integrated services. So at premise, maybe that is the clinic. Maybe it's a virtual behavioral health provider. Maybe it's at one of our fitness centers or one of our pharmacies. And those all become fish hooks in the ocean that we can use as a mechanism to introduce those individuals to other of our integrated services and to help bridge gaps that they might have. It also requires attention to detail. So we have physicians and nurse practitioners and nurses at our sites who are actively combing through registries, and they're proactively outreaching to patients and to individuals who might need to access care and reminding them that we are available in a number of fashions, not just physical, but digital also.
Kim?
Sure. I would agree. We've said a lot of these things, but I do think we are in a unique place. What we've done for the virtual population is we have absolutely addressed meeting the patient where they are. So whether it is through televideo or actually going to the home, you know, we're unique in that we are integrated with several other services. So if you have a telehealth service with MD Live, we need to integrate with those, you know, and so that we can see what's happening on that side. We have a unique relationship with home care. So we need to integrate with them so that we can see what's happening in the home. We have a unique relationship with a payer. So we have the ability to identify gaps in care, whether it's medication gaps through a PBM or seeing care gaps like through preventive services. So we see all of this and that integration and being able to provide that outreach because now we know who's missing services. And so how do we engage that population who hasn't been engaged? Then, you know, we can utilize our telephonic services, our televideo services, but they're all completely integrated into our on-site, near-site, shared site centers as well.
Catherine?
I think the pivot that we all had to make during COVID, it just rocketed us. We are better than we were. Virtual primary care has made our on-site primary care better because you're questioning every step of the process. You take it down to the studs and you rebuild it. I think it's been a revolution, and I just think we are there. We are right at the Holy Grail where all of these things can be integrated and where we can see all the data flowing back and forth. And it's far better than what the guy who puts out his shingle, because now we can use AI, all the stuff that's coming. I tease the people at Epic that they're running to us across a field with open arms towards the on-site world. They were built for hospital systems, but now they're building all of these incredible tools that I don't have to build because they're building them. And we're going to be able to use that to maximize schedule utilization. They've done that for ORs. They can get 15%, which for a hospital is a lot more OR time. And we can use that same AI and machine learning to increase our schedule utilization and get it as high as we can for those centers.
Thank you. Adam?
Sure. So first of all, I'd say I think this notion of hybrid workforce is actually kind of a funny one to me. And the reason I say that, if I look at our book of business, I have clients that are entirely in person and there every day. And then I have clients that haven't seen their employees in 3 years. And I think that's very much the way the workforce is today. Most of the folks that have said we're going to go hybrid, that actually just means nobody comes in. And I think because of that dynamic, the answer is very different. I mean, for our manufacturing clients, for our schools, for those folks, it's business as usual. And frankly, for a huge number of them, nothing really ever changed. And if anything, access to more virtual care, access to more mental health services, that's just a broader platform for them that helps them that they like. For our clients that aren't seeing people, and if you're a plan sponsor out there and you fit into that category, number one, I'd find a way to get your people back to work because I do think that will make a huge difference in their health and a huge difference in their lives. But to the extent that you can't do that, I think data becomes your friend. You have to be able to micro-target content to these folks. You've got to get the right access to data so that you have the ability to know exactly what individuals' needs are. And then whether it's the health center or it's any other solution that you have, being able to say, I'm not going to send you 20 communications, but the communication that's relevant for you is primary care. The communication that's relevant for you is the cardiac program that we have. I think the more specific you can get on that goes a long way towards being able to solve that type of hybrid delivery problem that people are struggling with.
Good. David, let's shift gears a little bit. At the end of the day, are your work centers saving money and improving quality? How do you know that?
Sure. In the end of the day, the answer is yes. We've been looking at this. We've been doing the on-site medical since 2009. One thing that we started doing at the very beginning is what I learned by the data guys was considered a difference in differences. You know, we looked at the total healthcare spend, what was happening to those that were attached to our clinics as their medical home versus those that are attached to primary care in the community. And we found that we were saving a significant amount of money. In fact, it got to the point Brand Corporation paid attention to us and they came in and actually did a study of what we would see. And they came back and they said in the total healthcare spend, we're actually saving on average $62 per member per month of those being attached to our clinics versus those attached to primary care in the community. And a lot of that was more on the qualitative aspects. That what we saw is basically they were able to reduce that overall hospital spend, emergency room utilization, a lot of the chronic condition type out things as we really not just focused on providing primary care, but really being in that medical home, working with folks, targeting chronic conditions and improving overall lives. And so, you know, not only do we say it, but they verified it. We saved money, and we saved money by, improving the quality of the care that was delivered.
Thank you. John, are you saving money and improving quality?
For individuals who are impaneled in our clinics, we are significantly reducing costs relative to overall healthcare spend. The more services that an employer chooses to engage with a premise, the more we save. Specifically, advanced primary care models where we have full-throttled integrated primary care, behavioral health, condition management, care navigation programs, virtual primary care, and pharmacy services. It's synergistic. And on top of it, those savings are accruing. They're getting bigger and bigger over time.
Adam, where's the savings opportunity?
I was really hoping somebody in the panel was going to say no, because I was definitely going to use that against, but I don't think that's probably not going to happen. So I mean, yes, we're absolutely saving folks money. It's something we spend a ton of time on. I think there's a couple reasons why, though. I mean, primary care in the United States is in a disaster state right now. You know, the number of patients people have to see, the amount of time that they have to do it. Before I started at Everside, I mentioned earlier, I live in Dallas. My wife decided she wanted a new primary care physician. She calls around, finds someone. He's like, absolutely, we can definitely see you in like 14 months. That is worthless, right? I mean, that creates no, like, the fact that anybody would ever say, be like, I'd love to schedule an appointment 14 months from now. But that's the reality. The experience is terrible. Net promoter score of primary care out in the world is negative. That's embarrassing. I think the other thing I would say is, you know, there's a reason that big health systems have bought primary care practices at a rapidly accelerating rate. And it's not just because they think they're neat. It's because it's the gateway for them. That's how they do lead gen into their system. And every one of you that's a plan sponsor should think about that. Every primary care clinic across the city of Nashville that's associated with one of those big health systems, it's there to funnel people into those institutions. And That is your reality as a plan sponsor. Doesn't mean it's bad care. Those folks are good people. They're doing good things, but fundamentally their goal is to get people into specialist care. So I think any movement you can make that shifts to the independent primary care model, that's what primary care was supposed to be 100 years ago, will inherently save money. And as long as you build the right structures on top of it, to John's point, you can ultimately expand the net. You'll catch more people. You can create a better experience. You can ultimately generate a larger ROI.
Phil, your thoughts about savings?
Yeah, two sides to it. I think from a primary care perspective, and I think the numbers may vary, some people may argue with me, but you're talking about generally 8 to 9% of health spend associated with primary care. So you're talking about using a high leverage point to get better outcomes on the other massive part of it. So your odds of return on that are really good. And we see it across the board. There's a lot of different measures and so forth. On a dollar over dollar basis, probably a little bit more expensive for primary care itself, but downstream, the impact is really high. And then on the pharma side, which sometimes is kind of left off of some of these models, depending on where you're at and what you're doing, because there's such bad behavior, quite honestly, it's actually not hard to save money in either carve out or in straight replacement. So for us, it's ducks in a barrel from a money saving perspective. The real key though is, and so in pharma side, you're talking about 25 to 30% of your spend. And I learned this early on because I used to go out to, and I probably called on everybody in this room at various points in the last 14 years. And I'd say, look, I'm going to save you 20% on your on-site spend. And they'd say, that's great, but I don't care. And we figured out that on-site spend was somewhere around 2 to 3%. And really didn't move the dial. And so the idea was, how do you move upstream from a value perspective? And pharma spends now 25 to 30% overall in saving money. That's good. So when you can address that and you can save dollars on it on a direct basis or beating the rebate game or whatever it may be, that's good. The real trick though is pointing it towards the big dollars. And so what we've seen is a great opportunity to tie, and this is an integration opportunity, but to tie another part of the spend and point it at very expensive things like diabetes or whatever it may be, chronic conditions, and actually bridge those together so that you can actually quantify it more easily. Yes, I saved dollar over dollar on the drugs and we had primary care happen. And guess what? We know that this group is going to probably spend 40% less on emergent care because they've been managing their diabetes and their A1Cs are down or whatever it may be. Those are things you can point to and show very, very, very analytically, and it's a good return on it. But the big deal on those is then it's also the lifestyle impact, because someone who's experiencing a blood sugar level of A1C of 14 or something like that, and you bring that down to 8 or 9, they are now functioning differently in their life. They are experiencing life in a different way. They are showing up. They're actually productive, and they're happy. Or at least happier. And so those are big deals. So the dollar side's great. Yeah, we can point to that all day long, but it's when we start pointing it at the overall experience and the results of what we're doing, that's when for us as advisors, as partners in this process, we can really point to something more meaningful.
Great. Catherine, where's the savings?
Yeah, obviously there's many studies that show the dollar savings for the people who are in these clinics, but you know, my father started Quad Graphics and then he started Quad Med. And Quad Med was part of this whole culture of employee-centered, building a company that's going to last generations. And so you have to think about that mission-based to what we're doing. So it's not just dollars. So I'm looking at Michelle Storbach and is sitting right there. Michelle came to Quad because she was looking for daycare for her kids. How do I put a price on somebody who's now been with the company over, a decade or decades? How do you put a price on that? We lost one, Quad Med lost an employee. Guess what? We got her back because she missed the Quad Med care that she got as a Quad employee. And so, yeah, we save dollars, but what culture are you trying to build at your company? What are you thinking quarter to quarter? We're a public company. My brother runs the business now. Boy, we have to think quarter to quarter, but we can also, because we're a controlled family company, we think in generations. I know some of our employers where we have the best impact, they're thinking not just quarter to quarter, but in generations. And this can be a foundational part of your culture.
Kim, last comment?
Sure, I would just, reiterate what everybody else here has said. I think beyond the dollars, and definitely we see a positive ROI, But beyond the dollars, it is that relationship that it's a change in culture. It's that relationship you have with the provider. In fact, we celebrated this week. One of our nurses at one of our centers was called out for just the work that she had done. And the outpouring of support that that nurse got from the employees that utilized that center was incredible. So I think you have to look beyond even the dollar. It is that relationship. And what does that mean for you as an employer? Because you create a loyalty to you that goes even beyond the healthcare savings that you get from the centers.
Thank you. All right, so we've got a few minutes left. Again, I said you have to participate. I haven't seen any text questions. So now's a chance, or I'll come out and I'll call on people. So any questions for our wonderful panel before we end? Nobody's, okay. So did you hear that question? Phil, why don't you repeat the question for those who are on the Zoom
I think
call.
the question was inflationary concerns moving into 2023. What are employers asking for from us in terms of helping them address some of what's coming down the pike? I'll take a first stab at that. I mentioned it just a second ago, which is there's lots of low-hanging fruit. And for those who need to address dollar for dollar savings, meaning I've got budget issues. We see it with union groups and other membership organizations, as well as our self-funded employers who are saying, a little concerned about this, not sure what the quarter over quarter looks going to be and what to anticipate. Basically, it's there. Even the best managed plans have got waste. And with a little bit of time, you can find them. We very rarely walk into a situation analytics wise and don't find easy places to save money. The bigger issue, I think, goes to a couple comments up here, which is really around how do we help our employees? How do we help them navigate? Because we're going to absorb it. Our organization's probably going to survive inflationary jumps, but we've got people who are making, say, $20 an hour or $70,000 a year, whatever it may be, who see gas prices go up, and it's like a choice. Could be a choice between my meds, or I've got to get food on the table, whatever it may be. And so the opportunity to rethink how we're addressing copays, deductibles, and why we do those things, the notion of cost sharing and what we're doing to subsidize, and getting away from what are basically patterns of behavior that have been in place for 50 years or whatever it is, some of it before my time, happy to say that. But we just do it because getting away from some of those things and saying, what are we really trying to achieve? What we're going to the table with it is saying, low-hanging fruit, we'll find some savings. What can we do to impact your employees so that their cost of care or cost of meds or cost of access, the things that are really hitting them dollar-wise, how can we bring that down so that we're not losing people because they're shopping for a 50-cent raise across the street?
We have another question that did come in. Do you have providers who are going to people's homes? And are you offering the service? So I'll start, John, with you.
Well, we're in people's homes every day. We have local virtual care, we have national virtual care, and we get into people's homes and provide care where they are anytime by that modality more than any other. As far as actually sending providers into homes, that's more limited at this time. That's something that we're thinking about and we're contemplating in the future. That there's some challenges with delivering service in the home, which is it is time consuming. And for us to be of greatest benefit with such demand now, oftentimes we find that virtual is an easier connector for us to maintain and to maximize capacity.
Tim, are you offering that?
Sure. We're unique. Our care delivery includes everything from our employer-sponsored health centers as well as home care, which is provided by physicians and nurse practitioners. We also have our telephonic, not only through our direct health, which is direct to employers, but also MD Live. And that integration between those groups, as well as some of our other care delivery modalities, that I think is unique to us because we are able to address all the needs for an employer.
Catherine?
They just call me and I show up at their house.
There you go.
No.
What's that number then?
No, we, other than virtual, which that's a provider into your home, right? And that's a big jump. We don't do that yet.
Well, I mean, we
now.
know that, at least initially, Amazon Care, for example, was offering you meet a provider virtually, and if you need someone, they're going to send someone to your home. Do you see that as part of the future of your centers?
And they just shut down.
And they just shut down.
But I don't know necessarily it's a provider, but a nurse, or that's where I think it's going to get interesting. And here's an example. At Quad, our magazines or catalogs come off the printing press in the way that the person walks, that the mailman walks the route, right? This is the logistics technology. And so, for instance, that's something Epic's building, that it'll link how the nurse should go from house to house, the easiest path, the most efficient path. So I think we're getting towards that. I don't ever see a time where providers will be going to the home unless you're in like Manhattan. So the concentration is,
Adam?
and you're a billionaire.
So I would probably remind folks in the audience, we're delivering primary care here, right? We're not doing ACL repairs in our health centers. I don't think anybody else up here is either. You know, I mean, I'm actually a huge believer in in-person care. I think in-person care is really important. I think the doctor-patient relationship is paramount. But so much of what you need to do to have effective primary care, to have effective mental health delivery, is engaging with the patient, understanding what their needs are, working on pharmacy strategy, and establishing the preventive care that they need to get. If you think about, and this kind of relates to the last question was asked before this, I mean, so much of what is driving healthcare inflation today is care people didn't get over the course of the pandemic. And a huge amount of that is preventive care, and a huge amount of that is chronic condition management. Things that can happen virtually, things that can happen in health centers very readily. And so I'd say that's where we're focused. But I think to Catherine's point, the world will continue to evolve. I think there will be interesting partnerships all of us will have. I think we'll have interesting acquisition opportunities that will allow us to send that into people's homes. But I agree, the probability we're going to send an MD into someone's house, pretty low probability.
All right, well, we're out of time. Sorry,
Can we get one more from the audience,
no,
Larry?
we're really out of time.
Okay.
The panel will be around for a little bit, but please thank Phil Berry and Adam Johnson, Kim Mutton, Catherine Cabris, and David Johnson.